So I will try to, of course, for the next few minutes, simply talk about nothing too dramatic, but thoracolumbar trauma, and we will try to focus to a certain degree on when to operate. Okay, so as we learned yesterday in watching some of the cases, there are basically four, or you can break one of them into two parts, four basic ways that you can break your thoracolumbar spine. And the simplest way is the compression fracture, as you all know, and the most profound way is the fracture dislocation, where everything went like this. That which receives the most press is, of course, the burst fracture, which is just a form of a compression fracture times two, where you really push down harder, and now bone goes in all sorts of directions, not just crunching in the front. And then finally, there's the chance fractures or flexion distraction injuries. We saw some examples of that in the cervical spine yesterday, where the focus of rotation is in the front of the spine, and the spine does one of these, and you tear up a whole bunch of ligaments in the back. Classification systems have been around for centuries, and this is the latest in the most commonly used today. Basically, it's the thoracolumbar injury classification system, which was profound for the first time, because as those of you, especially in orthopedics, know, in other types of fractures, we were principally interested in just what the bones look like. But for the first time a few years ago, the Spine Trauma Study Group got itself together and decided that there was a lot more in a spine fracture than just the bones broken. And these included the integrity of those ligaments and especially the neurologic status of the patient. So you would take a look at the TLEX classification, looks at the way the bone is broken, and it gives certain types of fractures a certain amount, certain points for their severity. And again, remember, all of these numbers are largely applied in order to help us decide if we do or do not need to head into the operating room. The second thing is the neurology involved. So if they're completely intact and they have no neurologic sequelae, then they don't get any points. But if they've got a complete spinal cord injury or they have a cauda equina pattern, they get a lot more points. And again, these points are trying to help us decide, do we need to go to the operating room or not? And finally, the third part is the ligaments in the back. Are they disrupted completely, rendering it a unstable burst type fracture, or are they completely intact? And all this is put together with the use of the three-dimensional imaging as well as the examination of the patient at the bedside in order to decide, do we need to go into the operating room or not? So if you add up the points and you've only got a couple, 1, 2, or 3, it's basically recommended conservative treatment. If you have point scores of up in the 7, 8, 9, 10, that is kind of a fracture pattern that lends itself more to surgery. The big crossover was those like a bursting type fracture with 4 points with a complete spinal cord injury as an example. So it also led us not only to decide, do we need to go into the operating room or not, but it would also help us decide the approach in which we would use. And as you can see here that, for example, the neurology is very important in terms of the posterior ligament complex as well as the quality of the fracture itself. And as I think, this slide shows this doesn't pattern out really well. But for example, at the top, if you're basically neurologically intact and the ligaments aren't busted up, you can basically decide, do I want to treat this in the front? Or a lot of times people treat it in the back. But second line down, once you disrupt those ligaments in the back, again, like we saw in a lot of cervical examples yesterday, you can see the recommendations become largely to take care of it from posteriorly. Switch it around. Now you've got an incomplete neurologic deficit, okay? You've got bone that's flown backwards into the canal from a burst fracture, but the ligaments are intact, so you don't need to reconstruct anything back there. You can see that the recommended approach by most consensus experts in the field becomes from the front. You've got to do something to get the bone away from the nerves and the spinal cord in the front, whether you do it through an anterior incision or a sideways incision or anything else like that. two lines from the bottom, you can see an example of a patient who has a complete spinal cord injury, but the ligaments are intact. Well, some people can decide to reconstruct it. It becomes half and half again in that situation. The AO spine thoracolumbar classification system is a cousin of all this, based on the same thing, but it was designed because even the TLIX has some creator bias. This was, remember, put together by expert opinion only, so that's level 5 data, level 5 evidence, and so they were trying to come up with a more universally accepted classification system that would apply itself all over the globe. And it's sort of a variant, but you can see now that we basically classify these fractures into those three main types that AO used. The compression type fractures labeled as A, ranging from simple compression of A1 all the way up to complete burst fractures there, the A4. And then because there was such wide international variation with their image interpretation, even the ability to have the machines to do this sort of thing, we wanted to have some sort of radiographic and CT evidence, because not an MRIs aren't always present in a lot of situations, but they do have CTs and radiographs. It turns out that this AO spine thoracolumbar, again, a simple variant of TLIX, turned out to be quite reliable in identifying the injury type and promoting the appropriate treatment as such. Again, 100 investigators from all over the world, and the overall kappa was moderate, but the inter-observer agreement when you use this new system of paring it down to the simple levels of A, B, and C turned out to be fairly reliable. So basically, thoracolumbar trauma, as you know, is divided into 3 or 4 basic areas. There's the thoracic spine up in the top, where we've got all the ribs attached and the sternum and the clavicle. Then you've got that sensitive area in between where the rigid thoracic spine meets the flexible lumbar, and that's the thoracolumbar spine where the majority of these fractures take place. And then there's that special area down at the bottom of the lowest part of the lumbar spine, typically that happens from axial type injuries such as falling out of trees. So the thoracic spine, as we know, because of all that supporting anatomy, it takes high degrees of trauma to produce an injury there. But when it does happen, the neurologic injury rate is the highest up in that thoracic spine, largely because of the anatomy involved. And there are subtle things like simple compression fractures here of T5, but you can see this, the sternum here has been fractured in this motor vehicle accident when they hit the steering wheel. So that reduces the overall stability of that thoracic spine. So it converts it into something much more dramatic within a couple days of actual disruption of the ligaments posteriorly without that strong anterior support. So high thoracic fractures can be difficult, especially if they're up above T7, because a brace or a corset doesn't control that very well. And you will oftentimes, if you do feel that you're going to treat this in some sort of orthosis, need to extend up into the cervical or even the head at times. So sometimes, even in relatively minor situations, now that we have minimally invasive techniques and technology available, the consideration can be given to posterior stabilization and instrumentation for what would be considered otherwise relatively benign fractures. Again, the thoracolumbar spine, moving down a little bit, the area most commonly involved with fracture, and the lumbar number 1 is the bone most frequently fractured. But as you can imagine, because the canal gets bigger down here and they were moving into the, from the spinal cord into the lower motor neuron region, neurologic injury is a little less common than up in the thoracic spine. But because that area, we're getting down closer to the lumbar spine where we bend and lift and twist, the chance for greater long-term disability and instability following the treatment of this patient is greater than following a thoracic area fracture. And finally, lumbar L3, 4, and 5, much less commonly fractured, but this is the kind of trauma that comes when you're jumping out of something like in the military, out of planes, or falling out of buildings, that produces things. And it's oftentimes the area much more commonly involved in the more elderly population that has osteoporotic, osteopenia, or other metabolic diseases. But again, because now we're getting down into the lower part of the lumbar spine where there's only a handful of nerve roots left, the incidence of neurology that comes from fractures down here is a heck of a lot less. But again, as anybody who takes care of any spine clinics with people who come in with low back pain, we know that we use the lower part of our lumbar spine more than any other part of the spinal column. So the potential for long-term disability following a low lumbar fracture is the greatest of any of the three basic areas that are injured. And the non-operative outcomes, even at 5 to 10 years, are not as good following a low lumbar fracture than those that we will see when you move up a little bit higher in the thoracolumbar junction. But it can be treated non-operatively successfully. Here's a burst fracture, as you can see, all the way down at lumbar 5, treated successfully with a external orthosis. And make note, as you can see on the slide on the right, that if you are going to take care of those lumbar fractures non-operatively in some sort of orthosis, because of its position, remember, a TLSO will only take care of the spine from L4 to the north. So anything from L4, 5, or down, if you're going to immobilize it, you need to incorporate the leg. And that line you see going right down the middle is a leg extension that wraps around that patient's thigh that locks that patient into position and thus controls above and below that low lumbar fracture at L5. And an example here, L4, this is what we're talking about earlier. A forest ranger that fell out of his stand suffers a fairly dramatic bursting type fracture of that bone. And you can see the canal is basically filled with bone fragments, including this one right here, which has reversed itself with the cortex now facing backwards towards the bone from whence it came. But all the way down at L4, you can, there's basically only about 6 nerve roots left, and each one, I think, must go into a special corner in that fracture pattern there and keep working. And this guy was neurologically intact, despite what you see there, and also treated non-operatively and able to resume his job. So compression fractures, again, the most minor fractures of which we deal with are oftentimes or rarely treated with surgery. The anterior column is the only part that's compressed, and the ligaments in the back, they're all intact. So they can more often than not be treated either with nothing or with a brace, or in certain situations, a little beyond the scope of today's talk, cement procedures, kyphoplasty, or in certain cases, vertebroplasty in the elderly type population. But in the younger individual who suffers a compression fracture, the treatment is typically, just for pain resolution purposes, typically going to be some form of external orthosis. At the other end of the spectrum are the fracture dislocations, where the upper part of the spine has gone one way and the lower part has gone another way, representing failure of both the bones in the front and the ligaments in the back. And these are the types that are most commonly associated with neurologic deficits and have fracture patterns, as you can see, like this. The upper part of the spine is in a different alignment than the lower part of the spine, and that by nature defines a fracture dislocation. And you see the spinal canal here filled with bone and a complete spinal cord injury in that regard. The thoracolumbar spine, again, these are the chance type fractures or flexion distraction injuries. They're primarily osseous in the elderly patients, but in the younger age groups, there can be typically ligamentous type injuries because the bones are so strong in that area. And here's an example of an x-ray that looks very much like that fracture dislocation that we just saw on the previous slide. Looks very similar to a slide that Dr. Dekatowski showed yesterday. But you can see this actually fortunate gentleman thrown from a motor vehicle at high speeds suffers traumatic spondylolisthesis, as you can see. So he has a flexion distraction injury of the upper part of his thoracic spine, but because it's spondylolisthesis, this back part stayed here and the front part went forward. And so despite the relatively dramatic appearance to that thoracic spine, as you can see sagittally, he's neurologically intact. And again, fracture dislocations, going back to that slide we talked about earlier, where there's a disruption of both columns, front as well as in the back, are treated 90% of the time with some sort of posterior construct and reduction. But as has been alluded to, one of the more controversial areas is that actually that fracture that is most commonly seen at the thoracolumbar junction and comes into an emergency room just about every night, and that's a burst fracture of the thoracolumbar junction from T10 down to L2, wherein the patient happens to be just fine otherwise. They're neurologically intact, and the ligaments are intact as well. But you've got a burst fracture. And 20 years ago, that was considered an operative indication because Francis Dennis felt that what he called 3 columns of the spine were fractured, or at least 2 of the 3 columns of the spine were fractured, and therefore needed an operation. But we wondered about this, and so we've studied this up on a couple of occasions and recently published now an over 20-year follow-up of a prospectively randomized study that we did wherein patients who came to see us when we were back in Minnesota received either an operation for their burst fracture, as Francis Dennis had described, or they got a corset or a brace, or in some cases a cast for the fracture. And then we looked at them 20 years later to see how they were doing. And what we saw at long-term follow-up is those patients who were treated non-operatively were much more comfortable on the visual analog pain scale. They were much more capable on the Rowland and Morris back disability score. You see normal being close to 24. And the Oswestry scores showed very little in the way of disability of the patients who were treated non-operatively, of course. And finally, the SF36, all indices favored the non-operative groups, with especially social pain and general health reaching statistical significance. More people who were treated non-operatively 20 years later were working compared with those who were treated with an operation at that time. So in association with our earlier study, where we found no real treatment, no real advantage to doing an operation for the neurologically, mechanically intact thoracolumbar burst fracture, those very same things. And this had nothing to do with the angle of the fracture or the amount of canal compromise, because we had some patients with over 70% or 75% canal compromise. I mean, bone completely filling the canal, but if they were neurologically intact, they remained neurologically intact 20 years later. And in fact, it may be that if you look at it over long term, that non-operative treatment may actually be significantly advantageous in these special types of people as opposed to doing an operation. And the people nearby, Dr. Kwan himself in the audience here, who you'll hear from later, took it the next step further and said, well, if we can get by without doing an operation versus wearing a brace, maybe we don't even need to wear a brace at all. So in this, with 1 year follow-up, they had a randomized collection of patients who either got a brace for that stable burst fracture, or they just got a little bit of instruction, a couple days of rest and rehab in the hospital, and then some education about taking it easy over the course of the next couple of months. And at 1 year, there was no difference in their patient-related outcomes. And there were actually 4 patients who did ultimately go on to surgery, but 3 of those 4 actually came from the group that was wearing a brace. So everybody in the audience knows or has had experience with the fact that some patients may actually, for these thoracolumbar burst fractures, even the mechanically and the neurologically intact, benefit from an operation. And as we saw also yesterday, patients with every other bone in their body is broken, it may be of some benefit to treat these with an operation to aid the rehab and the convalescence. The obese patient where you can't get a brace around them very well, remember, a brace only works as close as you can get to the spine. If your brace is in this county and this spine is in this county, it's not going to affect anything biomechanically. And so in certain situations, again, remember, now with minimally invasive techniques like Dr. Dekatowski will expound on, that may be an indication here. A special segment of thoracolumbar burst fractures is in the elderly, and I'll talk about that in a second or two. They're a special group that you need to keep an eye on. And finally, what we'll call the unstable burst fractures. Those are a little bit different than what we just talked about, but those are the burst fracture where the ligaments are in fact torn posteriorly, and those are the ones that might lead them best to an operative care. Because there have been some people, especially in Europe, who, contrary to, in direct opposition to what we concluded, have run similar type studies and actually showed better functional outcomes with patients who were treated operatively, and cost effectiveness of surgery versus trying to treat these patients with a brace, again at 2 years in Scandinavia, and also echoed by other authors in other journals. So it remains controversial, because what we want to know of now with the MRI, is this a stable or an unstable burst fracture? If the ligamentum flavum is torn, like you see right here in the supraspinous ligament, also injured like that, will that lend itself to become something that we don't want to have happen, and that's the maltreated or neglected burst fracture that was truly a flexion distraction type injury, but missed because of some of those subtle MRI findings. Because that diagnosis, which most ends up with what we call post-traumatic kyphosis, in this consensus statement, again from a similar group, were those untreated or maltreated flexion distraction type injuries. And that's why getting MRIs, and especially doing the exam, can be so important, are the ones most likely to produce painful post-traumatic kyphosis. And the load-sharing classification system of McCormick and Gaines that was introduced over 20 years ago was also very important to keep in the back of your mind. Because as there will be some subtle cases of burst fractures which felt to be neurologically intact, felt to be mechanically intact, but could have some of these disruptions anteriorly. And again, we saw that on the comminution of one of Mark's cases yesterday, that if that front anterior column is really, even if it's intact, but if it is so comminuted or so angled, it is felt that it might not support itself with a simple cast or brace, may lend itself to surgery. In a recent publication that came out of the group in Virginia, looked at, again, the same 70 individuals with intact burst fractures of the same region, but they were more kyphotic, more stenotic, and they had higher McCormick and Gaines fractures, meaning there was a lot more comminution in the front. They failed, 20% of them failed mobilization. They were too painful when they got up, and they went on to surgery. Now, there's a bit of subjectivity involved there, as we will see. I mean, pain is pain. We oftentimes had people that had painful fractures when they mobilized, but we insisted on staying the course with the corset or the brace. But so we weren't there in Virginia when they really were there to assess the pain. But their conclusion was that there were people that were too painful when they got up in a brace to tolerate wearing it in that regard, and went on to successful surgery because they had a high degree of comminution anteriorly. And the group out of China, Dr. Dai, who does more important prospective work in fractures than anybody else over in China, again, a similar situation of patients that showed that the loss of kyphosis and that loss of correction correlating strongly with pain was highly correlated to the load sharing score that McCormick and Gaines introduced 20 years earlier. And I mentioned the senile burst fracture, and that's a special cat, because as you can see here, this elderly person suffered a fracture, and basically because of the osteopenia, that L1 burst fracture basically disappears. And senile burst fractures have the propensity to develop late neurologic sequelae that the fracture in the younger people do not. These bones can slip, especially when they're at the thoracolumbar junction at the level of the conus. And the group out of Maryland published a small series of individuals, again, 10 patients over the course of 3 years in the elderly with a mean age of 70, who presented late, over a month after their symptoms, with neurologic compromise from what was originally a non-involved thoracolumbar burst fracture. So where you can take a younger person with a stable burst fracture and you can say, we'll see you in 2 months, the recommendation from our assessment of this is that in the elderly who has a burst fracture, even if they're neurologically intact, keep a much closer eye on them. I would have them come back every 2 weeks for those first couple months to make sure that nothing is developing, because oftentimes they're neglected, they're by themselves, or they're in situations where they're not taking care of the adequate follow-up, and you don't want to miss a conus injury developing late in that regard. Finally, we all know that patients thoracolumbar fracture with neurologic deficits do better when the bone has been removed and the spine realigned. Whether you do it from the front or the back really makes no difference and has never been shown according to the approach. The posterior can affect an anterior decompression if you go transpedicularly or through a costovertebral, or you can go directly anterior and remove the bone altogether. Certainly going in the front is more predictable and safer. Again, when you got situations like this, where this bone here has reversed itself and you're going to have to remove it, but it makes some sense in that regard. Thank you.